and welcome to a special CARP discussion on a topic that affects us all, cancer. My name is Marissa Lennox, and I'm the Chief Policy Officer for CARP, Canada's leading organization for older Canadians. We're here today to answer one vital question. Is our health system ready to care for a growing senior population? The Canadian Cancer Society says 1 in every 2 Canadians will get cancer in their lifetime, and 1 in 4 will die from it. While cancer can occur at any age, the vast majority, about 90% of Canadians who develop it, are 50 years of age and older. Within a decade, seniors will comprise a quarter of the Canadian population. Consequently, a 40% increase in cancer incidence is expected over the next decade. The good news is that enhanced screening and new treatments, including immunotherapy, are bringing hope and changing the way we treat cancer. Still, we know that as more Canadians are diagnosed with cancer, this puts additional pressure on an already strained healthcare system. So how can we ensure that our health system is prepared to meet this foreseeable, indeed inevitable, growth and demand for cancer? That's what we want to discuss with our expert panel. Each brings unique experience and perspective to this important question. Dr. Paul Wheatley-Price is a medical oncologist at the Ottawa Hospital Cancer Centre and assistant professor of medical oncology at the University of Ottawa. He is also president of Lung Cancer Canada, Canada's leading resource for lung cancer education, patient support, research, and advocacy. Dr. Larry Friedman is a chiropractor and president of his own diagnostic and medical testing company in Toronto. However, as a lung cancer survivor, he is here today to give the patient's perspective to our question. And Dr. Tina Sue is a specialist in geriatric oncology at the Ottawa Hospital Cancer Centre and an assistant professor of medical oncology at the University of Ottawa. Panelists, thank you for being here to talk about this very important subject. Now, Dr. Wheatley-Price, I'll start with you. We just heard a number of statistics that paint a very bleak picture. So I have to ask, is cancer inevitable? Even if you listen to your doctor's advice, you exercise, you eat well, is it inevitable?
Well, because it's not inevitable, because as you said, 1 in 2 Canadians might expect a cancer diagnosis, which means, of course, 1 in 2 won't. But I don't think the science is anywhere close to eliminating this disease really anytime soon. So we know that there are many behaviors that we can adopt in terms of healthy living, exercise, avoiding known carcinogens such as cigarette smoking or various others that might be out there. But despite that, unfortunately, many people will develop what we call sporadic cancers, where there's no clear explanation or there's no behavior that could have been changed. And once you've been diagnosed with cancer, it's really a moot point. You then have to deal with what you're facing.
Sure.
And as you said, with the population of Canada expanding and aging, I think, unfortunately, cancer is inevitable for many of us for the foreseeable future.
Dr. Sue, what do you see as some of the challenges currently facing the healthcare system in terms of providing cancer care to Canadians, particularly seniors? For example, would you say that there's a potential for ageism in the system in terms of providing care to a senior versus what care might look like for someone who's younger with cancer?
I think that's a really great question. I think the way our healthcare system currently is set up is not ideal for some of our older patients. And what I mean by that, I think that there's a couple of things. I think that we train our physicians, but many don't actually get training specifically in caring for older adults, and I think that can contribute somewhat. And the other thing is, I think that the way that we test all our drugs and all these new cancer innovations predominantly is in younger adults. So that even though older adults, patients 65 years and older, comprise 60% of those diagnosed with cancer, they only account for somewhere between 20 and 30% of those on clinical studies.
But why is that? Why is there a lack of data to treat seniors suffering from cancer?
Well, I think it's the way that we formulate our studies. So usually when companies are developing new drugs, they want to ensure that they're successful and that they work in patients who are the fittest of the fit. So not only are we seeing younger patients on these studies, but those older patients who are on the studies tend to be the fittest of the fit. But that's not the average patient that we see in clinic, and that makes it very hard. And I think that manifests sometimes as ageism, is that there's a lack of certainty in what to do in some of our older patients or some of our patients who are less fit. And I think that often leads to undertreatment or perhaps an inability to really inform our patients about those things that are really important to them. So some of my patients want to live as long as possible, but some of my patients want to live as well as possible. So what they ask me is, how am I going to function while I'm on this? Can I take care of myself? How is my thinking going to be? And those are things that our studies don't look at. And I think those are things that we really need to consider as we go forward.
Dr. Wheatley-Price, what about some of the other challenges? I'm thinking even geographically. If you don't live in major urban centers like Toronto, what access do you have to the best treatments and therapies that are available? Is that a challenge?
It is a challenge. I think it's worthwhile pointing out at this point that there are great treatments available, and there's been a lot of really huge advances in cancer treatments. I focus on lung cancer, and we've seen in the last just few years the emergence of really terrifically effective new treatments. So immunotherapy drugs are drugs that don't directly fight the cancer. They get our body's own immune system to do the work. Yesterday in my clinic, I saw a lady called Betty. She's in her 70s. She was diagnosed with stage 4 cancer, lung cancer, more than 5 years ago. And we never used to say people with stage 4 lung cancer would live 5 years, but largely because of immunotherapy, she's doing really well. Or Jacques, who's a physician with a rare type of lung cancer that can be treated with a tablet. Again, diagnosed 4 or 5 years ago. So there's these great new hopes, but the challenge is, I think, really coming to your point as your question of do we have access to that for everybody, regardless of how old you are, where you live, what province you're in. And there are real discrepancies, certainly from province to province, in access and funding for many of these new drugs. The time to get drugs approved, I think most of us agree is too long, could be streamlined and expedited. And really to get rid of these nuances almost, but they have real impacts on people who then can't access treatments. I was recently in Nunavut, and lung cancer rates and access to treatment for the Inuit in Canada is a real problem. But we see those things, I think, across the country.
Now, Dr. Friedman,
Yes.
you are someone who has survived lung cancer,
Right.
but you also have health-related professional experience. What was your experience like going through the system with lung cancer?
Well, I was originally diagnosed in the United States, and I was treated while I was working in the United States. So the initial phase was through the diagnostic process. It started off with a common cold, chest cold that just never coughed, it just never dissipated. And as that prolonged, I tried antibiotics, nothing changed. And finally, a chest x-ray did show something positive. Subsequent to that, the speed of the testing that was done was very impressive, because within a week, I had CT scan, PET scan, and MRIs done. And I think that takes a little bit longer in Canada, the expedition of that treatment. And then by the time I had biopsies done, it was all said and done. Within 6 weeks, I started first line of treatment. In Canada, I would say, probably because of the protocols, it would have taken double that amount of time, at least. And subsequent to that, I underwent the standard protocol, and then I switched over to immunotherapy. And the experience that was night and day between the chemo radiation that I had and the immunotherapy. The feeling of unwellness with the chemotherapy, although it saved my life, The immunotherapy let me conduct my life in a normal phase. I'm here today talking about that. So my biggest concern was when I was moving back to Canada, would I be able to get that same treatment here? And fortunately, it was seamless. I mean, the medicine in Canada is fantastic, except some types of treatments, such as targeted therapies, have become difficult. And I've learned that several of my friends have been waiting long periods of time to get government approval for these. And we're talking, I know one lady that's waited over 4.5 years to get approval for a certain targeted treatment.
In Canada?
Yeah, and she would have had it yesterday in the US if she had the insurance, obviously. But as time goes on, we see that, I believe that these testing and funding has to occur in order to support this growing cancer risk that we all have.
But you're not necessarily suggesting that people go south of the border to receive treatment. I mean, you've said that.
No,
Are there some benefits to the Canadian system that you
yes, like I said, we're getting there. Cancer has no borders. You know, whether it's the U.S., whether it's Europe and Germany, all this innovation that's happening is happening to help people survive. And it doesn't matter whether you live in Canada. We should be able to get more access to targeted treatment. Fortunately for myself, the treatment that I have available is available right here, and I see absolutely no difference for that.
Now, Dr. Wheatley-Price and Dr. Sue, I'll ask you both this question. We've talked a lot about the challenges in the Canadian health system and also some of the challenges just with cancer just generally. But what's the good news? What new treatments are available on the market now for people that are diagnosed with cancer? I'll start with you.
Right. Well, maybe I can just, I'll focus on lung cancer because that's where my expertise is. But I think a lot of the principles that we see in lung cancer are broadly applicable to many cancers. And there are some real hopes and challenges that come with that. The first thing I think we could make the biggest impact with is early detection. And that comes with screening. Lung cancer, unfortunately, number one for all the wrong reasons. 29,000 cases anticipated this year, 21,000 deaths from lung cancer across Canada, which is more than all the other common cancers combined. And one of the reasons for that is half the time people are diagnosed at stage 4, which is the advanced stage where the cancer has left the lung and is not curable. Now, screening has the promise to detect lung cancer at stage 1 or 2 when it's still in the lung and an operation can remove it and people can be cured. Just like mammogram screening for breast cancer, colorectal cancer screening, cervical cancer screening already exists. Lung cancer screening does not exist, but it is effective. We know it's effective, probably more effective than those other screening programs. So it's a great hope. The challenge is implementing that. There's a pilot program in Ontario and a couple of other provinces, but nothing uniform across the country, whereas it has been rolled out in the US, in the UK, many other of our peer nations.
How long can we anticipate that eventually coming to market?
Well, so I think that's a great thing for us to be working on, and particularly now when we've got elections coming up, and here in Ontario, where there is a pilot program, is to really lobby our elected officials to roll out lung cancer screening across the province. And it saves lives, and it also saves money, because if we can diagnose people and cure them, then the health system doesn't face the costs of having to prescribe very expensive drugs for long periods of time. The second challenge is going to be the new hopes of these new treatments and getting access to them. And the National Pharmacare initiative, which we've seen, is a promising start. There's nothing that's been legislated yet, but trying to kind of get rid of these inconsistencies across the country so people can have access to their drugs more quickly and without some of the barriers that Larry was just mentioning of someone waiting 4 years for access to a treatment, which is preposterous, really. So hopes, but challenges, and I think this is a good time actually with the election coming up to be addressing some of those issues, asking our federal government to increase the health transfers that come from the federal government to the provinces, so the provinces can then now deliver on things like screening.
Dr. Sue, I saw you nodding your head earlier.
Yeah, I agree with a lot of what Dr. Wheatley-Price says. I think that some of the hopes that I could highlight for our patients is that I know certainly for my older patients, there is a trepidation when we're talking about things like chemotherapy. So I think that there's interest in a lot of the new treatments that we have, immunotherapy being one, other targeted treatments. I think that patients are interested in treatments that are less toxic. They're also interested in treatments that they can take at home. So we are seeing more treatments that are come in the form of pills. So that's really important when you're talking about geography. I think about a lot of my older patients who don't want to burden their family because they don't want to have to come in from really far away. So I think that's really important. Those are things that are hopeful developments. Since I've been an oncologist, which hasn't been all that long, I've seen a lot of new drugs that are funded and available. I think that's one thing. And then the other thing specific to older patients is I think that there's increasing recognition, and I suspect that's why we're having this panel, that older adults are going to contribute the majority of patients that we do see. So I think that's both a challenge, but I think it's helpful because it's getting us on the radar. It's been highlighted by the Canadian Cancer Society in their publication a few years ago. And so people are starting to recognize this and the importance of that. So I think those are really hopeful things, and hopefully we bring that momentum and that recognition forward into some of our future plans and healthcare reforms.
Valuable insights. All right, well, a poll conducted last year by Ipsos Canada for the Canadian Medical Association showed that just half of Canadians have confidence that the healthcare system will be able to meet the overall needs of seniors. And earlier this year, CARP conducted a survey of its own members that was supported by Merck Canada to learn what they think about how the health system treats cancer now and how prepared it is for the future. Out of almost 4,000 respondents to the survey, more than 90% said their provincial healthcare system should make new investments to be better prepared to treat cancer, and that increasing cancer screening and providing timely treatment should be the healthcare system's top priority. So what do you think, and I'll put this to all of you, is the role of the federal and provincial governments, as well as hospitals, cancer agencies, and cancer systems, what is their role to plan ahead to ensure that they provide appropriate care for Canadians, particularly seniors and those affected by cancer? Dr. Wheatley-Price, I'll start with you.
Right, I think we've touched on some of these issues already, but just the fact that 1 in 2 of us is likely to develop cancer in our lifetime means that really the first ask is that please make cancer a priority. And I think we're all reasonable and understand that our health bodies have to balance a pie of money. And so, there are other issues, mental health, long-term care, home care, whatever those might be. But when 1 in 2 of us is going to get cancer, let's start. Just please make cancer a priority. Then secondly, I think, we look at the provinces as the prime deliverers of healthcare in our system. And screening that you mentioned is probably the best investment, because that's where we diagnose people at an early stage and where they can be cured. And it's effective in breast cancer and the other cancers we've mentioned. Lung cancer being the most common cancer in the country is the one where it seems likely that the biggest benefits can be made. The federal government's got a role there by investing in the provinces when they do the Canada Health transfers. So I think there's a lot that the governments can, both provincial and federal, can be involved in.
Dr. Friedman?
I think the key would be early diagnosis initially, and we talked about briefly about the pilot program that's going on in Ontario for low-dose CT diagnostics. Now, they did a study at Memorial Hospital in Hollywood, Florida, and where the hospital offered free diagnostic CTs to high-risk individuals, and unfortunately, the turnout was miserable. And I think it's because most people are like ostriches with their head in the ground, and if they don't know about it, they just avoid it. And they say, there's no possible way that I could have cancer. So the avoidance is a huge issue. Now, if the doctors and patients and their families should become more aware and educated about the situation, and they should be pushing these individuals to have these tests done. All right, so we get rid of that. The other thing is reduce the invasiveness of the procedure. If you if somehow in the future, and it's going to happen very soon, liquid biopsies, where you go in for a simple blood test, like originally now that they have the CEA, carcinoma embryonic antigen, but one specific for lung cancer or any cancer, where you go in for blood tests, same as a regular panel, CBC, and then you come out and it's either positive or negative. If it's positive, we get it treated right away, early, without any symptoms going on. The problem is, as a lung cancer patient, most of us are already symptomatic when we're diagnosed, and that means it's become advanced.
Could I just jump in on a point Larry made? There is some really cool science going on right now to try and get this early detection without having to do invasive testing. So there's projects that we've recently been looking to fund across the country, analyzing poop, analyzing urine, analyzing your breath to see if you can detect chemicals in your breath which put you at higher risk and then might lead someone into more intensive testing. So that this early detection, the science is really interesting, and so this field is going to change over the next few years. And I think what's really kind of nice for us is a lot of it's happening in Canada.
Yeah, definitely. Yeah. Dr. Sue.
Yeah, I agree completely with everything that's said. I think that cancer needs to remain a priority. I'm going to offer a slightly different perspective. I think that what's also really important from a governmental point of view and from a healthcare system's point of view is we really need to think about how healthcare is delivered to our older patients, and not just cancer as a general. Generally speaking, we think about cancer, and the issue of older adults is a completely separate topic, and I really think it needs to be integrated, and it really needs to be at the forefront in how we manage our patients. You know, some of our patients complain, I don't just have cancer. I've got cancer, I've got heart disease, I've got diabetes, and people shuttle off to many different specialists, and that people feel their care is very fragmented. So I think organization of care is really important. I think that the government and our healthcare system has to value time spent with patients. So, for example, a lot of our interest is in new technology and new ways to do things, and I think that's really important. But I think we can't forget that some of the best things we can do is spend time with our patients, find out how they're doing, what are their preferences, what are things that and this is high touch, low technology stuff. It's not sexy, but it's so important. So I think those are things that we do have to value from that perspective. And the last thing I think that's really important is we need to lobby places like Health Canada that actually approve drugs. And right now, many of the drugs are not adequately tested in our older patients, and our patients are less fit. And we've known that for a decade and a half. And yet we've made no progress. And I think that until some regulation comes in and says we have to do that, I think that things are not going to change very much. So I think that's incredibly important.
And I think that could be a role played by the general public, which lends itself into my next question. We're heading into a federal election. What can the general public do to raise awareness about these things, to raise awareness about what you've just been talking about, Dr. Sue? I'll start with you.
Yeah. I think there's a lot of things they can do. Looking, from the slant of someone who's particularly interested in the well-being and welfare of my older patients, I think that the things that I would say is, I would urge my patients and caregivers to, connect with patient advocacy groups and to lobby their elected officials or their upcoming elections to really have an influence on that. And I would say, more importantly, I think that it's important to have the voices of some of our patients who aren't usually the typical patient advocate. So our patients who are frailer, who have other priorities, because I think that they have different wants and needs. And I think it's really important for them to be heard. And if they're too unwell, and often they are, I think having caregivers there is incredibly important. So I think those are things that I would suggest, is having a representative at the table, I think, is incredibly important.
Absolutely. Dr. Friedman.
Well, I encourage everybody to show up to the Awareness of Cancer and Seniors Day on at the Parliament Building, Queen's Park,
Yep.
on December the 11th. Show up. It's something that's really, really important. You'll be getting an invitation, and look out for that invitation. It's coming.
Mm-hmm.
Well, so I think I'd echo what Tina said there about work with groups that are already existing, because then we can have a mass of voices trying to give a unified message. So with Lung Cancer Canada, for example, we've developed a 3-point message that we troll around the country, and anyone who'll listen, the city mayor, the provincial, federal politicians that we go and meet with, and we say, 1, lung cancer is the most common cancer in the country. Do you know that it kills more women than breast, ovarian, cervical, uterine cancer combined? Do you know that, et cetera, et cetera? So 1 is awareness. 2nd is screening and early detection, and that exists in many of our peer nations, but we need that in this country and in our provinces. And the 3rd is access to treatments in a streamlined, uniform, equitable, universal way across the country through something like National Pharmacare. So we have this 3-point plan, and we go out and we just repeat, and whether you're with Bladder Cancer Canada or Kidney Cancer Canada or Save Your Skin for the melanoma groups or any of these patient groups have all probably developed these messages, and we can go to our federal politicians now who are campaigning, and we can say, what are you going to do about the health transfers? What are your plans for National Pharmacare?
And certainly from CARP's perspective, we encourage our members to reach out to your local candidates. If this is an issue that matters to you, ask them what they're prepared to do about it, because they should have an answer if they're campaigning to be your local leader. All right, so we've sort of finished this round of the discussion. Now, I understand there's a couple members of our audience that are here and are ready to ask their questions. So why don't we go with the first audience member?
My name's Louise Binder, and I'm with Save Your Skin Foundation. My question is about the federal election. You've talked about some things we can ask the parties for. What about the issue of ensuring access for seniors to innovative clinical trials and also to putting money into research in these innovative therapies?
Dr. Sue.
You know what? Thanks so much for that question. I think it's so important. And actually, I think one of the most important things that we can do, either from the federal election, but also in terms of a lot of us donate money to places like the Cancer Society, is to say that that's really important, because we are able to direct dollars to research by actually saying that we're going to develop a campaign looking for grant submissions for older patients and looking for clinical trials. I know those are large. It's very hard to get research money nowadays. So having something directed will influence people to think about this topic and to develop those clinical trials and develop those studies that are important for our older patients. So I think that's one thing. The other thing that is important, that may be important and is certainly taking off in the U.S. as a movement, is to make clinical trials less restrictive, because many clinical studies are looking for the Olympians of our patient population. So they don't want you if you have heart problems. They don't want you to come in if you don't have enough supports. So all of these, or if you're not fit enough, which I think is important in certain ways. But I think we really have to be thoughtful about how we design our clinical studies so that they're more applicable to our patients. And I think by taking away some of those restrictions, we will naturally allow more older adults to be involved. I'll give one example. We have a study right now looking at more harder chemo or more intense chemotherapy in patients with higher risk cancer. And arbitrarily, it's designed as to exclude patients 75 or over. No rationale. I would think that in this day and age, that would be completely unacceptable. And yet we're still developing clinical studies that look like that. And that certainly enrages me, and I think that's something that shouldn't be acceptable. And certainly that could be something from a policy perspective to say, no, we will not fund studies with those types of restrictions.
What would it take to change it? Is it advocacy? Is it lobbying the
I think it's saying again and again that that's not acceptable. So certainly as a clinician, many of us attend our clinical trials group that, develops studies across the nation, and, raising your hand saying that's not acceptable. What are we doing? Or saying that we're not going to accept a study, having the strength to say that we are not going to do a study, even if it's good, even if it's interesting, that is going to have those types of restrictions on it, or that and to standing up to pushing back against some of the protocols that pharmaceutical companies come to us with, and say, no, we don't want to have patients who have kidney problems. We don't want to have patients who have heart problems, and saying, why is that? And really raising that as an issue. I think that's something we can do as clinicians on the ground and as patients. And I will have to say that patients sit on review boards of clinical studies that go through our institutions. They sit on these clinical trial panels. They sit on grant panels. And these are things that we can influence, okay? And then the last thing is to say from a regulatory point of view that that's not acceptable. If you develop a study like that, we're not going to fund your drug or something like that. I know it sounds a bit harsh, but I think that I can't understand why in this day and age that is acceptable.
Dr. Friedman or Dr. Wheatley-Price, do you guys have any insights on that question?
I agree completely. I mean, you're eliminating the boomer, aging baby boomer, from a clinical study that could possibly benefit, a clinical trial that could benefit their life and the future generations. I mean, how do you experiment without knowing that there is a possibility of a cure? And you gotta test the masses. And we are the boomers of the we are a voice.
And it really speaks to that ageism we talked about in the system earlier.
Yeah. I think there is a little bit of hope for this, Louise. As the eligibility criteria that Dr. Sue's talking about that restrict entry into research, there's been a number of initiatives in the US now with the FDA and various patient bodies and academic groups to try and really look at this eligibility issue to allow more people access to clinical trials, and particularly take off, often these arbitrary caps on, for example, on age. And most studies now don't have an upper age limit, but so it's a bit disheartening to hear that there are still some that do. So I think that's some progress. And then our ethics boards, who are kind of the gatekeepers of making sure that all clinical research that's done is ethical, and we're not doing arbitrary research just for the sake of it, but the rights of the patient are at the center. Our ethics boards, they also have the power to say, no, that's not ethical to run a study if you're going to restrict entry to various groups. So I think that there is hope, because a lot of that work is going on. But clearly from the example that you just heard, we've got a bit of a way to go. Yeah.
All right, well, thank you for that question. We'll go to the...
Hi, my name is Andrea Redway. I'm a lung cancer survivor from Ottawa. My question is about the cost of innovative treatments and how to improve access. I am wondering what you think, with the federal election coming, is the most effective thing the federal government could do to improve access to these new, very costly, innovative treatments for cancer patients across Canada.
Boy, I feel I need to stretch a bit to answer that question, Andrea. I mean, that is a question that we're all grappling with. And, if you look south of the border, at political campaigns in the States, that's always a big headline, isn't it? As we're gonna reduce the cost of drugs. And, they are very expensive. Some of the regulations we put into research does mean that performing clinical research is extremely expensive. So that's one issue. I think there's a bit of a debate about whether national Pharmacare will reduce costs. If a national Pharmacare system were to come into place, it's possible that they would have greater negotiating power. Having said that, already there's pretty much a national negotiating strategy for drug prices called PCPA, the PanCanadian Pharmaceutical Alliance. And so to imagine a new body, a Canadian Drug Formulary or Canadian Drug Agency, which is proposed, to imagine they would be able to significantly change that is maybe a little bit wishful thinking. I think what it might do, if successful, is get rid of some of the inequities of access. But the cost of drugs, I think, would come down if we do some more imaginative research studies. So, for example, we've had a number of studies with 70 or 80 people taking a drug, and it works in 60 or 70 of them. Boy, that's a home run by our standards if it's going to work in almost everyone. But still, a lot of the regulatory authorities will say, well, now you've got to go and do a 1,000-patient study where only half of the people will get that drug and the other half have to get chemo. And that trial will cost $200, $300 million to run, and then that cost then goes on the back end in how much we pay for the drug. So I think there's some things that we can evolve to doing, but I don't have an easy answer. I don't think if there was an easy answer, we'd have fixed this a while ago.
Dr. Freeman.
Well, I think there would be a fine balance between the cost of the drug and the research that is the funding of that research that's going into that drug. You don't want to go to the point and chisel down the price to the point where there's no incentive for the research to be conducted. So there has to be a fine balance of what's happening. And I think the government would have to, obviously, it's my opinion, there should be a redirection of funds. Since cancer is one out of 2 individuals in this room is going to wind up with some type of cancer at some point in their lifetime, the government has to reposition their ideas of where those funds are going to be allocated.
And I think just to add on, I agree with the kind of Canadian kind of strategy to try and see if we can bargain down some of the prices. The only other thing I would say is that there has been an emergence recently of what's called biosimilars or generic-ish versions of older drugs, and sometimes if we can bargain those, if we can bring those in, sometimes to access, bring down the cost of some of the older treatments that we have to allow access to some of the newer treatments. That might be a strategy to allow some innovation and allow access to some of the new treatments.
Mm-hmm. I know you had one last.
Yeah, just to think, I mean, there's sometimes a difference between cost and value. So the degree of benefit we get from a drug would have maybe an influence on how much we're willing to pay for it. But I think just one other thing on cost, there's been a worrying trend in the last couple of years where some drugs that we've been using for decades and are now off patent, and they're very cheap, and our buyers set a very low level of what they're willing to pay, which can't be produced for that cost. And so some of the generic companies will make these drugs as a sort of loss leader to get a contract where they can then sell other drugs. And what it's meant is that there's 2 or 3 very crucial drugs. Suddenly, there's one maker and they have an issue. And so right now we've got 2 or 3 drugs that we would use every week that we don't have access to. Mm-hmm. So there's the challenge with the new expensive drugs, but we also have challenges with our kind of old drugs.
Thank you for that question. I saw a few more hands go up. Was there one over here?
My name is Rebecca Hagee, and I would like to see prevention on the agenda, both for research and for active clinical practice. And we know that nutrition is a key factor in preventing cancer. And for example, in Ontario, we've had a kind of promotion of alcohol, which we've also heard is a class 1 carcinogen, right up there with asbestos. And what are we really doing to ensure that our seniors are getting the best preventive nutritional intake to stave off the day when they have to come for treatment or diagnosis?
That's an important question. I saw a number of people in the room actually nodding their heads as she was asking the question. So who would like to?
I have one. That's a really important and interesting question. I think that I like that you brought up the idea of prevention, because I think especially as oncologists, we're talking about mostly screening and after the fact. So in terms of prevention? I think it's a really hard question, really hard thing to do. One thought I do have, not specifically to your question of alcohol, but I do think that obesity is a big issue, and that relates to our lifestyle and our food, and probably is related to certainly outcomes in cancer. And I think that's a public health issue. And I think that the way that those things are going to be tackled is from a governmental point of view, from a public health point of view. So, for example, smoking only the decreased rates of smoking likely came from public health initiatives, right? So now we can't smoke indoors, and it's become more like that. So I think things like taxes on foods that are more expensive, or having some sort of thing to promote healthy eating, I think is the way that, from a societal point of view, where things are really going to improve. I think education is important, but it's very hard. I think that for people to make lifestyle changes, we tell people all the time, you need to exercise more, you need to eat better. We all know that. I don't think there's any person in the room that doesn't know that. It's the implementation that's very hard. So I think things like tax credits or different taxes I think that's how we're really going to change how and influence large masses of people to change their lifestyle.
Sure.
I think education is, although it's difficult, is probably the key, because otherwise you're fighting a never-ending battle up there. There are the McDonald's, the Wendy's, and I shouldn't name names, but anyways, fast food we'll talk to them about.
They're aware.
They're aware. Their nutrition content is not the best. Now, they've tried to do they have improved, but it's the people's choice whether they want to go in there and buy and eat. So education, as far as I'm concerned.
All right. Now, I know we have a couple more questions in the audience. One's over here, and we'll go to...
Hi, Marilyn. Before I raise my concern, I want to say, first of all, how lucky I am to be in Canada. I've gone through a lot of cancer treatments, and everything was covered. My concern is that the panel's talked about what we're doing in the federal election, about getting more money from the federal government. I am awaiting more radiation. I have to have an up-to-date MRI. I've been waiting for 3 months. There's no date set yet. I've been told that because of provincial government cutbacks, some of them are no longer operating 24 hours. There's a long wait. I could wait for 5 to 6 months for an MRI. So I would like to ask, what are we doing, what CARP is doing, and if the panel has any comments on, we get more money from the federal, but the provincial government's taking it away from us.
Wait times is a key priority for us, and as we head post-federal election, it'll be a core priority moving forward. So stay tuned for that information. But why don't we put now that to the panel? She's right. MRIs you wait way too long for them.
You are exactly right. And I think we're talking about the federal situation really just because of the timing when we've got an election coming. But I was at Queen's Park earlier this year at an event there, but we have seen health cutbacks in Ontario with the current government, and one of the biggest impacts that I'm seeing in the clinic, which is exactly what your experience is I'll request a scan because somebody's on a cancer treatment and we need to know if it's working or not. And I say, we'd like a scan in 4 or 5 weeks from now, please, and it just doesn't get booked. There are some ways maybe we can get around that. There are, I think some high load centers which take a lot of the work where the wait times are longer, and some of the work can be diverted to some of the smaller hospitals that have, perfectly excellent facilities that are underused. But we have seen these cutbacks, and we're worried at Lung Cancer Canada, we're worried about the screening program, which has been a pilot program in Ontario. It's leading in the nation. We're worried, is that going to be rolled out into a proper program? And a lot of people are having these issues about access, particularly to scans.
So my thought, I'm going to take a broader perspective. We advocate every day for our cancer patients to get access to scans. In particular, we work at the same center, so we're facing the same pressures. I think one thing to think about, because I think money is always, so having more money is important, but how we utilize that money and how we utilize the resources is equally important. So I think education and really looking how we're looking at using resources are important. For example, from a broader perspective, not necessarily just from cancer, is, are people getting tests that they don't need and for back pain or various things? And, I think that requires a broader look at the system. How often are people getting scans and such? So I think to make things a bit more efficient as well, right now as we have a set sort of resources, we have people coming in from all sorts of different, conditions and such. And I think that they're important, but we have to look at, there's been huge campaigns across Canada, for example, the Choosing Wisely campaign, looking at, certain things where where tests don't make a difference, okay? They don't change how well a patient does. It doesn't change what we do. And I think education and trying to improve utilization of the resources that we have is an important component, in addition to trying to get more resources. So I think it's a two-pronged approach.
Sure.
I think there's an issue here because a CT scan takes about 10 minutes. MRI could take half an hour to 45 minutes. They have a whole full study done. There's only so many patients you could see on an MRI. Obviously, they need more machines, or they need other diagnostic tools to use that are more specific. Like I said before, liquid biopsies, breath testing, all these other tests to restage patients during that period of time, or more machines, more MRI machines.
And ensuring they all run 24 hours.
They have to.
They have to.
They have to.
All right, we have time for just one last question.
Dr. Friedman mentioned immunotherapy as part of his treatment. I was wondering if the panel could explain what exactly is immunotherapy and how does it work?
The therapy that I'm on right now?
The immunotherapy.
The immunotherapy. The immunotherapy, well, I'm not a scientist. These are the doctors and other doctors and scientists. But they work on stimulating your own immune system to kick in and realize that those cancer cells are foreign and they're not part of your body and they have to kill them. And a lot of the time, these cancer cells have a protein around them called a PDL, and this PDL acts like a mask, and it creates, hey, I'm pseudo-normal, don't touch me. But once that PDL component of that protein is cleaved off, the body realizes that it is foreign, and the T cells, your immune system kicks in and destroys them.
That's about as good a way I could describe it.
I can't do it better than that. You can come and give a talk to our residents
Okay.
about it.
I sometimes use the example of Lord of the Rings, if anyone read those books, or the Harry Potter books, or if you're Star Trek fans out there. So in Lord of the Rings, Bilbo Baggins has this magic ring. He puts it on and he becomes invisible. Or Harry Potter's got an invisibility cloak he puts on. And I think it's the Klingons or the Ferengi can cloak their spaceships so they can't be seen. And essentially, that's what this PDL1 chemical and various other chemicals do. They sit on the cancer cells and become invisible. And the new immunotherapy drugs, they're generally intravenous treatments every 3 or 4 weeks. It takes about an hour, half an hour to an hour. And basically what they do is they're trying to take the ring off so the cancer cell is now visible to the immune system. And there's a particular type of cell called a T cell, and they get sort of activated and ramped up, and then they can go hunting for the cancer cells. And what's one of the really neat things about it is when they work, and they don't work for everyone, but when they do work, they can sometimes work for years. And we never used to see that with some of the cancers that immunotherapy works well in: bladder cancer, kidney cancer, melanoma, lung cancer, some cancers in the head and neck, some kinds of blood cancers. So they can be very, very effective, and they can have side effects like anything, but generally the rates of serious side effects are far, far lower than we would see with traditional chemotherapy.
Terrific. All right, well, thank you for your question. That's all the time we have with our panel for today's broadcast. I'd like to thank them very much for their useful information and perspectives. Dr. Paul Wheatley-Price, Dr. Larry Friedman, and Dr. Tina Sue, thank you so much. As our panelists said, There's an important role for everyone in helping get the changes we want and need for our health system. CARP's actively engaged on these issues, ensuring exceptional health care is one of our 5 key areas identified in CARP's FACES platform. Cancer care is a major component of that. Particularly with the federal election upon us, all Canadians should take the opportunity to raise healthcare issues, including cancer care, with their local candidates. And lastly, you can follow CARP's activities on our website, carp.ca. Thanks for watching this CARP panel on cancer. Goodbye for now.